Thank you so much. I greatly appreciate everybody coming out on this sort of nasty day and making the effort to meet with us. And it's nice to see a number of familiar faces here. And our topic today is to go through issues of lymphedema, facts and misconceptions. And my goal for this evening's talk is to first give you a background about surgery and issues of upper arm lymphedema. Certainly, if we don't know where we've been, we can't figure out where to go. So I'm going to spend a little time on the history of surgery and the history of the management of breast cancer and go through some of the evolutions, many of which are happening currently very quickly, which are changing both our approach to breast cancer, our approach to management of the lymph nodes, and issues revolving around lymphedema. So again, I greatly appreciate your coming tonight, and we'll start with our talk. So first of all, why are we interested all about lymphedema? Certainly as our breast cancer care has improved, our diagnosis, our management, we've become much more aware of the side effects and quality of life issues that are faced by breast cancer survivors. And we can first discuss what is lymphedema? What are we talking about? And the lymph system is a vascular system throughout the body, separate from the arteries and veins. These are thin-walled vessels that are throughout the body, and these carry not blood, but they carry protein, water, and white blood cells. The lymph fluid works partly to return body fluids back to the heart. Another important part of the lymphatic system is protection of the body, and this protection is provided by the lymph nodes. The lymph nodes are little bean-shaped structures that are clustered together in multiple areas throughout the body, and these work as filters. They catch objects, things that are dangerous to us, bacteria, viruses, large foreign chemicals that shouldn't be in the body, cancer cells. So the lymph nodes are a filtering system that work to cleanse the fluids and also serve to process some of these foreign bodies and help the body recognize them so the body can build antibodies and fight off these potentially harmful substances. And just to give you a sense of where the lymph nodes are, they're largely spread out through much of the body, clustered in the underarm area, the neck, the abdomen, and the groin. And these are, sort of where the major joints are, where the major different parts of the body join together, and that's where the lymph nodes are. In terms of breast cancer, of course, we're really looking mostly just at the axillary lymph nodes, but certainly, and particularly with surgery for melanomas, we can see lymphedema of the legs as well. And this is just a picture of what the issue is, sort of at its most significant, particularly the picture to your right. You can see in each of these two patients, they have a normal arm, and then they have a very edematous and swollen arm. And this is what we are trying to prevent from a surgical point of view, and what Laura and her group are dealing with to bring under good management. So this is sort of the more extreme issue. And why are we even facing this? Why is this a concern, a problem? Why is lymphedema sometimes seen as a result of axillary surgery? And again, we have to look back to the past. Breast cancer surgery, as we know it, really developed about 100 years ago. And one of the leading surgeons was William Halsted, a very famous American surgeon, helped found the Johns Hopkins School of Medicine, but before he went to Baltimore, he was a Bellevue surgeon for many years. So we feel very warmly towards Dr. Halsted, and actually he's buried in Greenwood Cemetery in Brooklyn. So a real New York boy. But he made the intellectual leap of proposing that breast cancer was not an incurable disease, but could be cured and managed under certain circumstances using surgery. Now again, you have to go back 100 years. This is a time where we're just beginning to learn about anesthesia. There's no mammography, there's no diagnosis for these diseases, and breast cancer was not the public health issue that it is now. You know, infectious diseases were much more problematic at that time. But this is a picture of Dr. Halsted on the right-hand side, and on the left we see one of his typical patients from those days. And what you're seeing is a large, what we would call today, locally advanced breast cancer. You can see the skin on the breast has broken down. There's a lot of inflammation and tumor present. And these were, on the other hand, she doesn't look particularly sick. You know, this lady's sort of sitting there looking off to the side. It's like, oh, I don't want to deal with this. But she's not ill. She doesn't have an active infection. And these were women who could undergo a surgical procedure because they were not otherwise ill. This is, I'm sorry about the pictures, but I just wanted to make another point. This is a more modern depiction of some of the types of cancers that were originally treated surgically. And again, this is what we today call a locally advanced breast cancer. You can see the redness is the cancer beginning to involve the skin of the breast. If you look up higher to the underarm area, you can see some red and brown and some protrusion, and that is involvement of the axillary lymph nodes. And again, this was the type of cancer that was being dealt with in the early 1900s, and these were the type of cancers that drove the surgical management, which at that time was complete removal of the breast, usually removal of the deeper muscles, and removal of all the axillary lymph nodes, or as many as the surgeon could remove, because this was the only option available for treatment at that time. You had big cancers, surgery, and really nothing else. And so there was no other option for the surgeons besides doing a wide excision of the lymph nodes. And it was important for two reasons. One was surgery was their only treatment, so they were trying to clear out all the cancer they could out of the axillary nodes as well as the breast. And as we said, our other treatments have really developed much more recently. Radiation therapy was first introduced in the late 1920s and really came into use about 2 decades later. Chemotherapy is sort of surprising to look back at this now for us because it's become such an integral part of how we treat breast cancer. But the first U.S. trials looking at chemotherapy, the treatment of cancer in the United States, were started in 1957. So these are relatively recent treatments. So early on in treatment of breast cancer, we were locked in to surgical management. There was no other option. And some of this thinking has carried over to surgical management really up until recently, when we're beginning to re-examine the role of the axillary lymph nodes and the amount of surgery that is necessary to treat women. But the lymph nodes have always been considered, and really up until recently, to be the most important factor for determining women's prognosis and outcome from breast cancer. So we've always looked at the lymph nodes as sort of the window for breast cancer. If the lymph nodes were clear, we considered these to be more favorable cancers. Lymph nodes were involved to be a more aggressive cancer. And I'll speak a little bit later on, but as our understanding about molecular genetics, biomarkers, and the biology of breast cancer has evolved over the last 20 years, these ideas are changing, and thus our surgical management and approach to the lymph nodes is changing greatly as well. And this just sort of summarizes what I was saying. These days we recognize that among breast cancers we have at least 4 different subtypes. And you may have run across this if you've been looking on the web or heard discussions. There are what they call luminal types, there are the triple negative breast cancers, there are the Herceptin or HER2-neu subtypes. And each of these acts a little bit differently. Each of these have different patterns of spread, and some of them, including triple negative breast cancers, may be less likely to go to the axillary lymph nodes. So our approach to the lymph nodes has changed greatly. Much earlier diagnosis. We understand biology better, and we're looking at the lymph node now not as a reservoir of disease, but as an indication to help us in making recommendations for treatment. So our whole thinking about this and our approach is very different than it was. So as opposed to what Dr. Halstead was facing 100 years ago, we see a very different landscape looking at the management of breast cancer in the United States today. Very, very common disease, picked up very early, about 250,000 new diagnoses of breast cancer yearly here in the United States. I'm sure many of you have heard these statistics very often before. About 40,000 deaths per year from breast cancer, and we have currently about 2.7 million breast cancer survivors in the United States. So survivorship, quality of life becomes a very big issue because this is a big population of women who've undergone treatment and whose quality of life and experience want to optimize. And again, looking at the overall survival rate for breast cancer, this is a disease that we can do very well with. And the overall current survival, looking at women who were diagnosed and treated in the early 2000s, overall for our all-comers in the United States, our survival rate is 89%. And again, this is just a little more data going through our patient population and why it's imperative that we have rethought our approach to the axillary lymph nodes. The majority of patients in the first line have early disease, stage 0 disease, non-invasive, non-traveling breast cancer, stage 1 disease, a true invasive breast cancer, but one that has not moved, a small cancer that has not moved out of the breast yet. This is 60% of all new breast cancer diagnoses in the United States. Another third are cancers that are localized to the regional area, the breast, the lymph nodes, but no further metastases. And about 8% of patients currently present with disease outside the breast area. And we're looking at disease in the bones, liver, lungs, outside the breast and the regional lymph nodes. But again, you look at the majority of our patients, most have regional disease. Our overall survival rate is excellent for these women. So even in the second group, even the patients who do have lymph node involvement, they have very good survival. So we have to be looking at what we're doing to keep these women well. And this is just another schematic looking at the underarm area, giving you a picture of the lymph nodes under the arm and giving you a sense of the different levels of lymph nodes and what we're doing with our sentinel node biopsies. And again, as our diagnosis has become earlier and earlier, the majority of our patients do not have lymph node involvement, and so earlier surgeries where the lymph nodes were cleared out of the axilla is largely unnecessary, and we're trying very hard to back away from that. And what we can do currently is identify the first lymph node, which is the redder node here, the first lymph node that drains the breast area. And this is the first node that's going to be catching those tumor cells or anything else dangerous traveling in that area. If that lymph node is clear, we know that the other lymph nodes behind it are clean as well. So this allows us to very selectively test 1 or 2 lymph nodes and leave the rest of that area undisturbed. And the impetus for this was, 1, to minimize the amount of unnecessary surgery. Removing healthy, normal lymph nodes provides no advantage to our patients, and also very much trying to reduce our surgical side effects, our surgical complications. And this was nicely illustrated by a very big study sponsored by the American College of Surgeons, which was published in the year 2007. And this study involved thousands of women who underwent either sentinel node biopsy alone or a sentinel node biopsy with removal of more lymph nodes, with an axillary lymph node dissection. And you can see that for all categories, we certainly have more problems with the bigger surgery. Patients who had the axillary lymph nodes removed had a higher rate of infection. They tended to sequester or store more fluid under the arm. And the last category, which is sort of the focus of this talk, is we certainly saw more episodes of lymphedema with the bigger surgery. And certainly the more lymph nodes that were removed, the greater the risk of developing arm swelling for these women. And looking at the differences in the 2 surgeries, the sentinel node biopsies, we average usually 1 to 3 lymph nodes on average that are removed, while with an axillary dissection, the surgeon is aiming to get usually between at least 6 to 20 nodes to make sure that the area has been well evaluated. One caveat here is that there were a number of criticisms of this study in the fact that the lymphedema rates we thought were a little bit high for the sentinel node biopsy population, and reported rates run anywhere from 2 to 6% following sentinel node biopsy. So what are the risk factors for lymphedema? And again, surgical issues play a big role in this. The risk is probably, as we said, about 2 to 5%, 2 to 6% after sentinel node biopsy. If we do see lymphedema after sentinel node biopsy, often it's not as severe as that we see following an axillary lymph node dissection. The risk of developing lymphedema after axillary dissection, after removal of multiple lymph nodes, is a little debatable. Different publications, different authors have come up with very different numbers. Some of this depends on when the patients are examined. Some studies look at the patients, within the first 6 months after surgery, and we know that we can see lymphedema development months to years after the original surgery. So those studies probably underestimate the amount of lymphedema. Many of these studies have not been very scientifically rigorous in how they've evaluated lymphedema. The surgeon may look at the arm and say it looks fine or it looks swollen. They may get the patient's input, but not many of these studies have measurements of the arms before and after surgery and measurements of both arms because we're not symmetric. And depending if you're right-handed or left-handed and various other reasons, your arms may not be the same size. They may not contain the same internal volume even without surgery. So comparing them after surgery has some issues. But again, after lymph node dissection, we think the risk of lymphedema can be up to the range of 30%. And what compounds these risks? And there's a number of issues. Infection. Certainly a bad infection that involves the axillary incision may interrupt the lymphatics or scar them down permanently, and this can result in an alteration and a blockage to the lymphatic fluids leaving the arm. Obesity. Certainly women with a higher BMI are more prone to lymphedema. And there's concern, although not great evidence, that weight gain after your breast cancer surgery and treatment may also perhaps contribute to lymphedema. The number of, not only the number of lymph nodes that are removed, but how much disease there is in the axilla. So a woman who has multiple lymph nodes involved or a large amount of tumor in the axillary area, again, you can imagine this will cause obstruction and blockage of these very fine, delicate vessels, and that's another risk for lymphedema. And finally, radiation to the axilla, particularly when it's used in combination with removal of multiple axillary lymph nodes. Now, because of all the problems with lymphedema, this has been a very feared complication, and for many, many years, there's been a lot of advice and efforts made by physicians and other health professionals caring for these women, trying to prevent this. And much of this falls, I'm sure Lori sees this a lot, falls into sort of the category of urban myths in a way, because these are ideas that are sort of passed down from teacher to student, and not necessarily based very well in scientific information. So women were advised for many years not to use the arm, not to do heavy lifting, not to do vigorous exercise, not to carry their pocketbook on that arm, not to work for a long time at the computer keyboard. It was thought that all of these things would precipitate lymphedema. And I'm sorry for this slide, it's a little complicated, but this is again being reevaluated and rethought, because we know that fluid in the arms goes back to the heart because of muscular pumps. So it only makes sense that a stronger arm should have a good circulation. And people have begun looking at the role of exercise in women with lymphedema, and this trial, which was published in the New England Journal of Medicine, garnered a lot of public attention and a lot of write-ups in the lay press in the year 2009. And this was a study of women doing very slowly progressive weight training, and it was found that weight training did not worsen lymphedema, but if it was handled in a very controlled situation, many women found that their lymphedema was stable or got somewhat better, and some of their symptoms got much better. So again, this is forcing us to reassess and re-look at our previous do's and don'ts about how women should be exercising and acting and using that arm, so that they're not afraid to exercise and be active. This brings in another issue, not related to lymphedema per se, but to breast cancer survival. And there is a fair amount of information available that both weight control and vigorous exercise 3 times per week for women who've been treated for breast cancer may be helpful in preventing recurrence of disease. So all of this seems to fit into a different model for how we should be instructing our patients to care for themselves. And instead of being afraid of their arm and afraid that they will precipitate lymphedema, we want our patients, after the immediate post-operative period, once it's safe to start, to be physically active, to exercise, because of many, many benefits from this. That being said, there are still a number of issues and number of things women can do to take care of themselves and to try to prevent the formation of lymphedema. We think that, as I mentioned, the lymphatic channels are very thin and delicate, and we like to make sure that they are not interrupted or compressed or obstructed or stretched or interfered with immediately after surgery. So usually we don't begin very vigorous exercise until a few weeks after surgery. And there are a number of things that can aggravate this issue as well. High heat and burns to that affected arm. Again, issues of weight gain. We're concerned that this may precipitate or increase lymphedema risk. Constriction. We want to make sure the circulation remains good and the arms can empty out. Role of compression sleeves for airplane travel comes up all the time, and there's different approaches to this. My patients know how I feel about this. And importantly, to avoid infection. And that is really the reason we still advise women, if possible, to avoid blood draws or blood pressures on the arm where they've had lymph nodes removed from, because we're concerned about trauma to that arm. And certainly, if you've had a cut, a scratch, a bug bite, if you're a gardener and you've gotten a bad scratch from your rose bushes, anything looks at all infected or slightly red, call one of your physicians right away, because this does need to be treated with antibiotics very quickly, and one of your healthcare providers should be looking at the arm quickly to make sure that things are being handled in a timely fashion. So what are the signs of lymphedema? And we showed those pictures earlier, but very often it'll first show up as some swelling in the wrist or the hand. You can also have, in some situations, lymphedema of the breast, and the breast itself can retain a lot of water, become very swollen, and not be able to drain out easily. A new, heavy, or full feeling in the arm. You notice that the skin gets swollen and red. Again, most likely a sign of a coexisting infection. You find that clothes that used to fit are now tight or snug around the arm. Your jewelry doesn't fit anymore, even though you may not have gained any weight. So these are all signs that there may be some arm swelling. And again, I'm just going to go briefly over the treatment because we've got the expert here, but it's very important to work with an experienced therapist, and this becomes really a long-term issue because while we can control lymphedema at this point, although there's some interest, which I'll talk about briefly at the end of the talk, at this point we don't have a cure for it. So once an issue of lymphedema develops, it really requires vigilance and self-care. And these are just going through some of the treatments that are available with our therapists in terms of using manual lymphatic drainage, again, to empty out the arm, get that excess water out of the arm, massage for the arm, wrapping, so you can control the volume of the arm and keep the fluid out of it. And again, it's not a hopeless situation. And if you do develop lymphedema, we have a lot to offer and a lot of support, but a lot of progress we can make. And this is the same lady before and after, going through her course of treatment, and you can see the difference in the arm. The hand swelling is gone, the arm swelling has gone down. We're letting her wear nail polish. You can still have to be alive and human. So there are things to do. And these are some slides from our lymphedema group here. Again, just going through what I've mentioned in a more organized fashion. We want to prevent infection. If we see arm swelling, we want to start to act right away to prevent it from progressing, using manual decompression to empty out the arm, to use compressive sleeves and such to try to keep the arm empty. Proper exercise. And really this becomes a very personalized program that you work with your therapist in terms of what's right for you and what works for you. And we have a wonderful program here. We're very, very lucky to have our lymphedema group here. And I have many patients who come from outside the institution wanting to come into the program. So what else can we do? And there's interest not only in treatment, because by that time the horse is out of the barn, but what can we do to keep the horse in the barn? And so along with changes in our surgical management, switching from axillary dissections to sentinel node biopsies, particular attention to how the surgery is performed, trying to minimize returning to the operating room for removal of more lymph nodes after a sentinel node biopsy. We're also looking at other approaches, and Dr. Mei Fu, who's a doctor of nursing here at the NYU Downtown School of Nursing, has been very interested in this project as well, and she has embarked on an education program for our patients where they get preoperative measurements of the arms. They get preoperative education about exercise and how to care for the arm. And she works with our patients very closely in the immediate postoperative period as well, looking to give as much education as possible and hoping with this to minimize the risk of developing these more severe issues of lymphedema. And this is the perometer, which is a newer way of measuring volume in the arm, and we like to do this before and after surgery. This is one of the most objective ways for really seeing what's going on in the arm instead of being eyeballed by the surgeon. Oh, you look fine, your arm is fine, don't worry about it. Here you have numbers before surgery and after surgery, so here you have data instead of conjecture. And we're looking at some other projects as well, trying to see if we can identify some of the inflammatory factors that may contribute to this. There's a great deal of interest not only in lymphedema but in the whole field of breast cancer development in the role of inflammation and how this may be a trigger for breast cancer development as well. One of the other projects that is going on at the Clinical Cancer Center is an outreach program for lymphedema to our Chinese population. The last thing I'd like to discuss just briefly, and I don't have the slides on this, but is another approach to lymphedema. Besides physical therapy issues, massage, compression machines, we have a laser program going on now at the Rusk Institute as well. But another option, which we here in the U.S. are sort of waiting to see how it plays out, is a different approach to lymphedema, which has been championed in France, which is lymph node transplantation. And I'm sure some of you may have read about this on the web. There was a big article talking about this in the New York Times last winter, and the thought is that if you can remove normal lymph nodes from elsewhere in the body, and remember we saw lymph nodes everywhere, the other underarm area, the groin, the abdomen, the neck, The thought is that if you can take these normal lymph nodes and transplant them into the underarm area of a woman with lymphedema, these lymph nodes may be able to promote development of these lymphatic channels and help to draw fluid out of the arm. Certainly a very appealing idea. We're still waiting to see how this plays out. Part of the surgery is very, very delicate, and it involves the surgeon giving a small injection of colored dye into the arm, following this up so that they can identify the lymphatic channels and know where to transplant these lymph nodes into. So there's an enormous amount of change. I think the biggest change has really been a mindset change in terms of how we approach the axial and the axillary lymph nodes. I think as surgeons, we have had a mindset change as well, and we're becoming very aware of lifestyle issues, survivorship issues, things that may have been poo-pooed 10 years ago when the patient may have come into the office and complained, and the physician would say, "You're lucky you've got your breast, you're lucky you've got your life, stop complaining." It's a different world now. 89% overall survival. We expect our women will do very well. Even our women who have more advanced disease, even women, say, with bony metastases of breast cancer, we can expect to treat these women and keep them going for a very long time. So we are looking at survivorship and quality of life as very, very important components of breast cancer care. It doesn't finish with the chemotherapy or the surgery or the radiation. Our job is really to see that lifelong we get you into the best place possible. And I'd like to thank everybody for their attention today, and thank you for coming out in the evening.